Good evening and good afternoon to some of those around the world. Welcome, everybody. My name is Brian Lewis. I'm the president of KidneyCAN, and we're a research-focused patient advocacy organization, and I'm broadcasting from Philadelphia. So thank you very much for taking time out of your busy day to join us. This is our third in our town hall series, and tonight's topic is optimizing your kidney health. We just really appreciate you hearing and listening to these experts tonight. We had 143 registrants for tonight's town hall, and that represents 31 states and about 8 countries. I heard Finland, Poland, Australia. So thank you for making the time to join us from around the globe. We want to give a special shout out and a thank you to our sponsors, Bristol Myers Squibb, ASI, Exelixis, Genentech, and Merck. Without your support, these town halls wouldn't be possible. So thank you very much. And especially thank you to our expert panelist, Dr. Hans Hammers. He's a medical oncologist from the University of Texas Southwest in Dallas. And we're also joined by Dr. Matthew Abramson. He's an Onco-Nephrologist from Mount Sinai in New York City. So welcome, Dr. Hammer and Dr. Abramson. Thank you.
Thank you, Brian. We're excited.
Thank you for having us, Brian.
Looking forward to this. So for those of you that are new to the town hall experience, our format is to have each of our experts give a little bit of context for the discussion and a little bit of background on their thoughts on optimizing kidney health. And then we're going to hear from patients and caregivers from both across the country and possibly around the world asking their questions to the experts. And don't forget, at the end of the program, we're also hosting a special social hour for viewers. And you can you'll get the dial-in on the chat later on, but it's a forum. It's very informal, and it gives you an opportunity to discuss any topic just about you want to with some of your colleagues from around the world. So wait for that at the end of the evening. So let's get started. Dr. Hammers, can you give us a brief overview of your title as a medical oncologist, and then we'll turn it over to Dr. Abramson for a little bit.
Sure. So, as you well know, if it comes to oncology, cancer treatment, there are several different specialists that kind of like work hand in hand together. There's a surgeon, a radiation oncologist, and a medical oncologist. Medical oncologists are internal medicine doctors, meaning at some point we knew a little bit about the kidney as Dr. Abramson does. Patients see us in various stages of disease. They can see us for high-risk patients where we use immunotherapy, meaning patients who have not recurred, or unfortunately recurrent kidney cancer patients. And I'm the person who would deploy, quote unquote, chemotherapy. We don't give chemotherapy, we give targeted therapies and immunotherapies. But I'm the guy who caused a lot of problems with the therapies. And my job is to oversee the therapies, keep a balance of drug exposure and benefit, and also identify problems, and then call on to my colleagues if things are getting more complicated, like Dr. Abramson, for example, to manage some of those issues.
Great. Thank you for that setting. Dr. Abramson, tell us a little bit about Onco-Nephrology and what that means, and then please share some slides if you have some information for us.
Sure, absolutely. I'm going to go into exactly what an onco-nephrologist is. I have a very short slide deck just to kind of give an overview of how a kidney doctor kind of has a role in the cancer patient's journey. So what is nephrology? What is a kidney doctor? How can nephrology help in your cancer journey? So nephrology, just like Dr. Armour said, it's a medicine specialty, just like oncology. Same baseline training of internal medicine. We manage the medical aspects of kidney, including kidney function, which we'll use the term GFR. You may see this term again later on. Patients who have kidney injuries from treatment, from surgery, other reasons. Patients who have long-term kidney dysfunction. Patients who have high blood pressure, either related to the kidney or as a primary disorder. And patients and management of electrolyte abnormalities, including sodium, potassium, magnesium. So what does the kidney do? The kidney cleans blood of certain toxins, mainly breakdown products of protein, as well as cleans the body of cancer therapies because cancer therapies are toxins. But it actually keeps the good stuff in. So there's a barrier that protects all the good things from leaving, like the proteins in our blood. The kidney manages blood pressure, manages blood volume, meaning your salt in your water. And it fine-tunes your electrolytes. And finally, it produces certain hormones, like it activates vitamin D. It produces a hormone that tells your bone marrow to make red blood cells, and it actually regulates your bones, the calcium in your bones. And what is kidney function? Kidney function is by all estimation is related to a blood test called creatinine. And creatinine is a blood test that's done pretty much every time you see a physician, either whether it's an oncologist, nephrologist, primary care doctor. It's part of the basic metabolic profile. And we take that creatinine level, we put it into a calculator. Creatinine is the main contributor to the calculated kidney function, but other factors include age, gender, and sometimes your body size. It is not a true measure of kidney function, but it's an estimated kidney function, and we'll call it an estimated GFR or eGFR. When I think of a normal kidney function, before I see a patient, just if I'm seeing a set of labs, I usually think of a normal kidney function when there's a creatinine of 1 or an eGFR of more than 60. So if the creatinine is greater than 1 or the eGFR is less than 60, then that's possibly chronic, an abnormality in kidney function. When you have protein in the urine, it's showing that the kidney is stressed, even if the kidney function is reported as normal. So chronic kidney disease is when the kidney function is lower than those numbers we discussed before for a period of about 3 months. Or if there's protein in the urine where it shouldn't be there, because usually the kidney is a barrier to prevent protein from leaking in the urine. Problems related to poor kidney function. You could have something called uremic encephalopathy, is when you have confusion, fatigue, nausea, vomiting, usually when the function is less than 15. And that's because the toxins aren't being filtered out properly by the kidney. You may have difficult to control hypertension or electrolyte abnormalities that are also difficult to control. And you may have swelling, volume overload, fluid overload. Why does kidney function matter in cancer? Low kidney function may preclude you from clinical trials and from certain treatments. If your kidney function reduces during your treatment, it may interrupt your treatment. And if you have reduced kidney function where your function is very low, you may be at risk for needing dialysis. So my goals as a nephrologist or an onco-nephrologist is to minimize time off cancer treatment and help optimize cancer treatment as able. And finally, my final slide before we'll go on to the questions, what is an onco-nephrologist? Onco-nephrologist, it's a relatively new concept. It focuses on patient-centered individualized care. It's a subspecialization of nephrology. Just like Dr. Hammer says, he facilitates cancer treatment, but as a nephrologist, we actually don't prescribe cancer treatment. And this subspecialization often requires extra training in the management of cancer patients, usually associated with an academic center, like an academic hospital. And it requires close and trusting collaboration with oncology and urology from different aspects of medicine, including clinical, academic, and research. So I'm going to finish there.
Great, great. Thank you, Dr. Abramson. I appreciate that. And thank you, Hans, for setting the table with the. So I'm going to kick it off by sort of asking a softball question. We talk a lot and put on our website information about building a care team early on, in your diagnosis or when you're involved with kidney cancer. When would an oncologist and an onco-nephrologist start working together or start taking care of a patient together? Can you just give us some information around that?
Yeah, so Actually, at various points in the patient journey. A more and more frequent visit these days with the advent of adjuvant therapy is that I see a lot of high-risk patients who had their kidney cancer removed and are at 30-50% chance for recurrence over the next 5 years. And a lot of these patients, come in, they just, recovered or are recovering from the surgery and are just getting, used to thinking about kidney cancer, but also that they only have now one kidney left. So it's actually a very common topic during the very first visit that I have with patients is to discuss that they have just one kidney. A lot of questions come up during that time, and I, especially if the GFR that Dr. Abramson mentioned, if that is decreased, if the number of the creatinine goes towards 2, for example, that's the latest time when I say, hey, it might not be a bad idea to actually get a nephrologist on board. And the little joke that I typically make, and I hope Dr. Abramson is not offended, is that, nephrologists fall in love with your kidney, just your kidney. But the good news is whatever is good for your kidney is good for the rest of you. So it's actually really good to have a nephrologist on board, because whatever makes the kidney function long time will be good for you, for all your blood vessels and for your long-term survival. So I think that is a very common initial referral point, actually, without me giving any therapy. And then later on, when I start causing some trouble, and that's when I knock at the door of the nephrologist. So typically, like proteinuria, if I feel there's an autoimmune process involved. So when I need more help in managing the patients optimally, that's when I hope for people like Dr. Abramson. And to be clear, I was really excited actually about this topic, because I do think we need more onco-nephrologists. I would say the more common scenario, especially if you're in private practice, is that it's difficult to find a highly motivated nephrologist who wants to work very closely with the oncologist and think together about some of the issues that we are dealing with. So I can count on one hand where I had really good interaction. So I do think, he is a new one in an emerging species of specialized physicians. But I'm really grateful that he's here and will share his expertise with us. So thank you so much.
Great. Thank you, Dr. Hammers. Dr. Abramson, just teeing off what Dr. Hammers said. So do you see, or how many newly diagnosed patients do you see sort of in a weekly basis? Are they seeing you early in their care path? Any comments around that?
That's a great question, Brian. And Dr. Hammers, I'm not offended about your understanding of nephrology and your and your hesitancy to refer. I think that the we are usually become involved late, not early in the patient's cancer journey. I would say in the middle or towards the end. And I think that if we're involved a little sooner, we could develop a better rapport with both the patient and with the rest of the care team, oncology, surgeon, et cetera. And we can be a little more proactive, I believe. I believe there's a lot of room for improvement. Coming in late to the cancer journey can be really challenging for the nephrologist for a lot of reasons. One is that actually you gave an interesting cutoff of a creatinine of 2, and then definitely when I see a creatinine of 2, I'm concerned. Depending on the case. Because by the time the creatinine level is 2, the function can be below 30%. And once you get below 30%, that's the time where you may be at risk for needing dialysis in your lifetime. So I think that instead of looking at the creatinine, probably good to use those estimating kidney function equations. If a patient has a function of around less than 30, then I think it's definitely reasonable to consult nephrology. I would argue 45 probably. I have a few other slides for that if anyone's interested. But I am on the more of the proactive side. That being said, I also agree that adding more physicians to a patient who's already coming to see doctors multiple times a week, it is definitely burdensome for the patients. We have to weigh that as well.
Okay.
Now, you mentioned once patients with having nephrectomy or removal of a kidney. We do see a lot of those patients. The removal of the kidney itself is not usually a problem, although there is usually a kidney function reduction. But that usually stabilizes over time. But that does increase your risk for kidney disease progression in the future as well.
Great, Dr. Abramson and Dr. Hammers, I'm going to reach out to some of the folks that are calling in from around the country. I think our first person is coming in from Judy from Massachusetts. So let's see if we can get Judy to come up here and ask her question.
Hi.
Hey,
Yes,
Judy.
I had a question whether we should be seeing an onco-nephrologist versus a nephrologist when we have one kidney due to kidney cancer.
Who would like to
Dr.
take?
Dr. Abramson, I think it's for you.
Okay, I'll take it. So onco-nephrology is a relative, like I mentioned before, it's a relatively new concept. There are not that many onco-nephrologists, only a few hundred probably in the country, compared to the thousands of general nephrologists. So depending on where you are, if you're not near an academic center, then you may not be able to see an onco-nephrologist, at least initially. A general nephrologist has the skill set to manage a lot of these issues. Whether or not the concern that Dr. Hammers made earlier about, is there a motivation or are they maybe if they're not up to date with the literature, they may be maybe a little behind in managing some of the minutia. But the more common adverse sequelae of kidney disease can be managed by a general nephrologist. That being said, if you're not happy with the care you're getting, or your oncologist is not happy, you can look into if there are any onco-nephrologists in your area. One way to do it, first of all, look up the closest academic center to you, and then look up their nephrology division. Many of the major academic centers do list onco-nephrology now on their website, and they'll tell you who is part of that clinic. And you can reach out to them directly, to their office directly, or if it's not obvious, you can reach out to the general nephrology division and ask them if there is an onco-nephrology specialist there.
Great. Well, thank you, Judy. Appreciate the question. Thank you for coming on. All right. Well, before we start talking about side effects, can each of you talk about the management of patients with rare subtypes or hereditary kidney cancers who may have multiple kidney tumors removed over the years? Dr. Hammers?
Yeah, happy to. I mean, as Dr. Abramson mentioned, it's really more like the successive removal of functional kidney tissue that comes with the removal of the mass, right? And so the question really is, where do you end up in this year-long journey? For some of the syndromes, like if it's clear cell kidney cancer, for example, we have now some very exciting drugs like belzutifan that may suppress new outgrowth of lesion or diminish the chance that you need a surgery, at least for some time. So it's still something we need to learn. But yeah, I mean, the risk really is more like somebody has to go in successively, either remove a whole kidney or pieces of a kidney. And then over time, you will end up with less and less of this precious tissue that can filter. And that, I think, in my book, is the main issue.
Dr. Abramson, do you any comments regarding subtypes or hereditary kidney cancers that you encounter?
I think just like Dr. Hammers said, the problem with the genetic forms of kidney cancer are that they frequently have multiple site. They're multi-site. They're on both kidneys. They recur, and the loss of when you remove those tumors, whether it's with surgery or cryoablation, you are removing good kidney along with it, and it can be very challenging. Aside from that, the most common form of genetic kidney disease is not a cancer itself, autosomal dominant polycystic kidney disease, but those patients do develop cancers as well. But I see that on occasion in my clinics. And those also are patients that are very challenging to manage. But yeah, I think what Dr. Hammer said already kind of summed it up.
So when patients have multiple kidney tumors, do you advise getting genetic testing?
Yeah, so so yes, so if somebody as young as multiple kidney tumors, I do think it's very appropriate to consider. There's certain guidelines that we follow now, especially if there's a family history, for example, is a very important component of that. But yes, in principle, if you see more than one and you feel it may not be purely sporadic, especially younger age, family history, etc., it is very advisable to see a geneticist, and they can then discuss with the patient, what is the probability that a certain test deployed can be useful in a certain situation. But yes, so typically it's one of the classic factors that we look at when we consider genetic testing or referral to geneticist.
Okay. So this came in from someone in the audience. Most of our patients that take VEGF therapies for years. Can you describe the VEGF landscape and how do they cause renal functions and how do you identify and manage those problems? And maybe you want to just take a moment for those who don't know what VEGF is, just give a brief outline. I don't know, maybe is that for Dr. Hammers on the VEGF or Dr. Abramson, you want to try?
I'm happy to start, and then hopefully Dr. Abramson can help me there. So VEGF stands for vascular endothelial growth factor, and that is one of the main molecules that will induce new blood vessel formation. It's also, if you look across different cancers, it has really its highest expression levels in clear cell kidney cancer, because the oxygen sensing and the expression of that particular molecule is linked. And as you also probably well know, clear cell kidney cancer lost the ability to see oxygen, and then VEGF levels go sky high. So it's a growth factor, and that's the reason why kidney cancers typically are very bloody, friable, very easily bleeding tumors, very blood vessel rich, and we see that on the contrast scan. They're typically very nicely contrast enhancing tumors. The VEGF inhibitors were and still are clearly a main component for the management of metastatic kidney cancer. In fact, when they first came along, we were desperate because nothing really worked in large amounts. Classic chemotherapy didn't work. And with really the understanding of science, biology, the work that Dr. Kalin and others have done and got awarded with the Nobel Prize of Medicine in 2019, that understanding really led to the testing or encouraged testing of VEGF inhibitors in clear cell kidney cancer. In fact, they don't work for almost any other cancer well. So these are very unique drugs. These are the targeted therapies that we talk about, the pills. And the mechanism is not that they kill off the kidney cancer cells directly, they really go after the blood vessel supply. And as Dr. Abramson will elaborate, is that the kidney has these little specialized organs, tiny little organs where the GFR comes from, that are essentially blood vessel coils. And so if you design a therapy that goes after blood vessels, it's almost guaranteed at some point you're going to cause trouble there. And with that, I give over to Dr. Abramson. He can elaborate on that.
Yeah, so patients on VEGF inhibitors is one of the most common referrals that we get. Actually, because what happens with the small blood vessels in the kidney the kidney senses that there's a problem, and by trying to counteract the problem, it raises the blood pressure, thinking if you raise the blood pressure, we'll have better flow through the kidneys. So very commonly, you will develop either new onset high blood pressure or worsening high blood pressure if you have a baseline of high blood pressure on these treatments. And it's very common, probably at least around 50% of patients will develop new onset or worsening hypertension throughout their course of treatments. Another issue with the VEGF inhibitors related to the kidney is because those blood vessels get a little bit damaged, sometimes there can be leakage of protein in the urine. And that leakage of protein can be a very small amount, or it could be a very large amount, or somewhere in the middle. management of those issues can be very nuanced. If it's a very large amount, often requires interruption of treatment. But if it's a smaller, moderate amount, it can be managed with medications.
Great. Well, thank you for that. I think we're going to bring up our next question from the audience. I think we've got, I hope I'm pronouncing this correctly, Pavel from Poland. I think there you go.
Yes, hello, and thank you very much for letting me ask my question. And the question is about my daughter, who is 27 years old, had a nephrectomy in December 2020. And since May 2021, she's been on Lenvima. And for the good part of 2023, she has had proteinuria, and the question is, how can this be managed, or how this should be managed?
Pavel, do you know how much protein there is in the urine? Did they?
Yeah, well, the highest was something like 2.5 grams per liter. Now well, 3 weeks ago it was 0.5 grams per liter. Blood pressure is okay, and creatine is something in between 1.1-1.2 milligrams per deciliter, and GFR is 53. At least it was in the 50s, so to say.
Yeah, it's a very challenging situation. I think with a protein level ranging close to like 3, at least close around 2.5 or 3 grams, that is a significant amount of protein, because that's telling me the kidney is definitely under some stress. Usually when there's protein leakage in the urine, the kidney will probably slowly deteriorate over time. Some patients with this situation, we do have treatment interruptions or dose reductions if the oncologist feels that it's appropriate from a therapeutic perspective. And I think that if she did not have a nephrectomy, if she didn't have a nephrectomy, if she had 2 kidneys, I would consider biopsying, one, to see exactly what the damage is being caused and how much scar tissue has developed already. Scar tissue in the kidney is not usually reversible, but there are some findings that could be reversible. Now, having just 1 kidney, the risk of doing a biopsy is high, because you don't want to have a complication with that 1 working kidney. So that's a very nuanced discussion. If treatment is continued, there are medications that can lower protein in the urine. Typical antihypertensive or blood pressure medications like angiotensin receptor blockers or ACE inhibitors, those reduce protein in the urine. And I think there's been a new push for what's called the SGLT2 inhibitors, which are traditionally a diabetes drug, but they've shown in patients that actually have kidney disease not related to diabetes, they too can have reductions in protein in the urine. And there are a couple others actually too that can help reduce the protein in the urine. But I think it's reasonable just to have the discussion with the local nephrologist to see if a biopsy is, would be 1, safe, and 2, if it would be helpful to kind of figure out the future treatment plan.
Okay.
Yeah, and from my perspective, so obviously your daughter is young, so I don't know what kind of kidney cancer she has. It really depends on
TRCC. Sorry to interrupt. This is translocation.
Translocation. Yeah, so it really depends on the scenario. Obviously, with translocation, renal cell carcinoma, immunotherapy is probably not the most effective therapy. At least you cannot rely on it. And so, if you don't have too much alternatives, right? The question is, how dangerous, so to say. So what I'm trying to say in many words is, my sense always is, and Dr. Abramson can correct me if I'm wrong, but my sense always is, you can push it along only so much. So let's say once the nephrotic syndrome, these large amounts of proteins, once that's coming, it's very difficult to you may get along for a little while before the creatinine goes up, but there's only so much they can play with drugs that can lower protein in the urine, like ARBs or ACE inhibitors, etc. But at some point you will need a break, right? And the question is how do you do that, and what's the scenario, right? What's the disease burden? Does it make sense? Do people feel it's so dangerous? Is it just a tiny little amount of cancer that could potentially be irradiated and give the patient a treatment-free interval, for example? So starting to think about creatively about the cancer itself, and how can you set yourself up for a potential treatment-free interval or not? And I think those are discussions that you would have to have with the oncologist and with the nephrologist. But it's a little bit, so Lenvima, to take a step back, lenvatinib, it's a very potent drug. I love it. It's a very good drug, but it is a little bit more notorious than some of the others with regards to proteinuria. So it's one of the highlighted side effects that we see more pronounced with Lenvima than maybe with some of the other pills. So alternatives can also be, for example, sometimes even then, like after a break, maybe even switch to another class, keep the Lenvima in the back pocket if it worked for you, and then go back to it at some later point. So it's a difficult scenario. There is not a one shoe fit all. It's really one where you need to have, I would say, discussions really to develop a plan. What happens in 6 to 12 months when it's getting harder and harder to control the proteinuria and the creatinine is going up?
Well, we've got thank you, Pavel. Appreciate the question. Dr. Abramson, an audience member asked the question, what do you consider a large amount of protein, and what is the best test for trying to determine that?
Yeah, so an initial screening test of a urine protein dipstick is certainly reasonable. And if you have more than trace, I would say if you have 1+ or more, I would quantify that amount of protein in the urine. It's just another spot urine test. I'm not advocating the need to do a 24-hour collection, and it's called a UPCR, urine protein to creatinine ratio. So that's what I would advocate if it's at least a 1+ on the dipstick. That being said, concerning an amount of protein in the urine, it's kind of difficult to say, because in general in nephrology, we always think of any amount of protein is abnormal. Like if we have a spot test of like more than 300 grams of protein, or 300 milligrams of protein or 30 milligrams of albumin, that would be abnormal. But patients on, as you mentioned, on the VEGF inhibitors, at least half of them probably have some protein level in the urine. I think if there's more than about if there's over like a half a gram of protein in the urine, or 150 milligrams of albumin, which is one of the proteins in the urine, then that should at least prompt the consideration that maybe nephrology may be helpful. And that would probably, even that level would probably more in the preventative stages. I'm saying, I know that the VEGF inhibitors cause protein in the urine. What can we do to kind of reduce that risk of it worsening? Once, like Dr. Hammer said, once you get into the grams, from milligrams to grams, once you get into the 2, 3, 4 grams, that's really concerning. And that makes me as a nephrologist think that the kidney function could start deteriorating rather fast.
Right. And sometimes, sometimes, as I said, you are with the back against the wall. You don't have good alternatives, right? So there will be some patients that might have a disease burden, for example, by taking even a short break. We know that the moment you stop the pills, disease can spring forward. It might be actually detrimental, for example. So it really depends on the scenario. Are they just controlling 1 or 2 lesions? Can they probably irradiate? Is it a different kind of cancer where we have no alternative therapies, right? For example, could you use immunotherapy, for example, or some of the other newer drugs that are coming along, like belzutifan, is knocking at the door. A HIF2 inhibitor, and typically well tolerated, and that could be an alternative that you could switch out the mechanism that you're using for disease control and give the kidney a break. Again, it's not a contraindication then later on to go back to this class of drug. It's a very useful drug. It's a mainstay of therapy for kidney cancer, no doubt about it. But the question really becomes at some point is, what are some of the alternatives to get the break? And it may take months for it to improve, actually.
Yeah, I'm going to stick with this topic just sort of close. Another question was around what kind of pain medication can you take for pain and a headache? And the person, a patient was told to stay away from Advil or Motrin and told also not to take Tylenol because it interferes with immunotherapy. Is that any comments there? Truth to any of that? All of that? None of that?
I let Dr. Abramson answer the NSAID story because all nephrologists they're very much adamant about the NSAIDs.
Yeah, the problem with the NSAIDs like ibuprofen, Advil, Motrin, and Aleve. First of all, they're wonderful anti-inflammatories. They work fantastic at therapeutic doses. The problem is they are toxic to the kidney if you take it chronically long term. They also mess with the blood vessels in the kidney, causing blood vessels to constrict, so there's less blood flow to the kidney. It's a very controversial topic. A few times it depends on your kidney function. Depends, it also increases blood pressure. So if you're going to take, if you need to take it as needed, couple times a week, or that's totally reasonable. But if you're taking it for chronic pain multiple times a day, it's a very nuanced discussion you should have with your providers to see if that's a safe strategy.
Yeah, and then coming back to Tylenol, I'm not aware of data that Tylenol is immune suppressive. It's certainly not something that I tell my patients. You have to sometimes be careful with large amounts of Tylenol because of a different organ, which is called the liver. But outside of that, I don't see it as an immune suppressive agent. I'm not worried about that immunotherapy wouldn't work. At least I'm not aware of any significant data sets that would recommend us not to, or to strongly discourage the use of Tylenol. Tylenol is a very safe medication up to a certain gram range that we like a lot. It's not nephrotoxic at all, but it can certainly be a problem for the liver if you take too much. And then opiates generally are safe. Again, a different class of drugs. They don't have anti-inflammatory components, and you get other complications like constipation, etc. But so among those, with a palliative care team, often you will find a good way to control pain.
Great. Well, another sort of general question here. Kidney cancer patients many times have high blood pressure or diabetes, sometimes pre-existing, sometimes caused by treatment. How does your team manage these problems? Toss-up question.
So again, blood pressure, let's put it this way: if the patient was already it has already primary care physician and they're already coming with 2 or 3 medications for the diabetes and the blood pressure, I tend to not get involved and defer to the primary care physician. If things get complicated, and they sometimes do very quickly, for example, with blood pressure, we have fantastic onco-cardiologists. So the theme is, if the moment you send them to a specialist that has the name onco in it, I tell you, you get fantastic care. And then we have also endocrinologists who work with us very closely. We give them a lot of business, unfortunately. If diabetes gets more complicated, or if I cause diabetes, I do that unfortunately from time to time, and then they also get involved. But I would say for the general bread and butter, a little bit playing around with the blood pressure, etc. Now, an onco-nephrologist may think differently, so I'm happy to hear how Dr. Abramson think about. They may get more involved with blood pressure control and be a little bit more aggressive about the targets than the primary care physician, but that's essentially a turf to them.
Yeah, that's a very interesting perspective. And I think from my institution, we also have very, very good cardio oncologists, like you had mentioned, for hypertension. And we even have some endocrinologists who also kind of subspecialize in onco-endocrinology as well. So, it's sometimes better not to have too many physicians trying to make the decisions on the same with the same drugs, because even from physician to physician, everyone will have a different opinion, and it's just very confusing for the patient. Usually when nephrology gets involved in a high blood pressure case, it's usually high blood pressure related to kidney disease. One of the problems with kidney disease, whether you have reduced kidney function or you have protein leakage in the urine, that tends to worsen high blood pressure. If it's a high blood pressure alone problem, we're not usually called, especially not called first. That being said, we do kind of shoot for normal range when we treat high blood pressure. That's as close to, the top number is close to 120 and the bottom number is close to 80 as possible. Sometimes it's not possible, so we're okay maybe in the close to 130 range on the top number, but we really try to get the bottom number close to 80. And as for patients with pre-existing hypertension and diabetes, they are, just the studies have shown, they are at increased risk for kidney complications with treatment. So that is just another risk factor to think about. If you want to take a proactive approach in involving nephrology.
Great. Well, we have another question that's coming from a patient in Oregon. We've got Werner, I believe, on the line here. And Werner, you want to ask your question?
Yeah, thank you, and thanks again for the seminar. For patients with one kidney like myself, and I've been on treatment for stage 4 since 2021. Now I'm off treatment. I was curious. This was maybe indirectly asked, the creatinine trigger level that may indicate a need for a nephrologist on my care team, because mine's always been, since I've had one kidney, if I remember right, it's always been in the 1.5, 1.6 range. So that's my question.
Yeah, I mean, so I can tell you what I'm currently practicing, but again, I am here to learn also from Dr. Abramson, quite frankly. So 1.5, 1.6, to me, I'm not too worried. But first of all, let me take a step back. The common question is, hey doc, I have just one kidney. How does it work with treatment, cancer therapy, kidney cancer therapy? Is there contraindications, any problem with just one kidney? And the answer is no. We can give therapies essentially at any kidney function level. Now, we do recognize that some of these drugs have some kidney toxicity. So if you're like in the 2.5 range, even way before then, obviously, but let's say, then I get much more nervous about a TKI causing problems. Less so about immunotherapy. Immunotherapy is more like, yes, you get it or you don't get it. But the TKIs are more the chronic toxicity, for example. But yeah, so 1.5, 1.6 is a very common scenario. Quite frankly, I don't get nervous about it per se. Now, learning from Dr. Abramson, maybe I should send more of my patients to an onco-nephrologist, but I think I would have to hire him to have somebody like that at my institution.
That was a great perspective, Dr. Harmers. And Werner, thank you for the question. So after someone undergoes a nephrectomy, usually their kidney function stabilizes to a certain level, whether it's 1.5, 1.6, 2. If they're coming in with normal kidney function prior to nephrectomy, I wouldn't expect it to be worse than 2. If it's worse than 2, that's definitely a concern. Now, if your kidney function is stable for years, you're not currently on treatment, your urine does not have protein leakage, then I think that 1.5, 1.6 is totally a reasonable kidney function, and you should not be at risk for dialysis. However, if you're planning to do, like you said, if Dr. Harmers said, planning to do treatment with TKI, immunotherapy, you have pre-existing hypertension and diabetes, those risk factors with the creatinine of 1.5 or 1.6, I would consider a nephrology referral. And like I said earlier, looking at creatinine is good, but I usually just go by, I use the calculated estimated GFR, where you plug basically you plug the creatinine into a calculator and it gives you kind of a percentage. And if the number is less than 45%, I think it's reasonable to consider seeing a nephrologist. And if it's less than 30, then I certainly would recommend it. In some people who are older, they have low muscle mass, a creatinine of 1.5, their kidney function actually could be quite low. So maybe just a second set of eyes just to say, oh, things should be okay, or if there additional workup is needed.
Well, thank you.
Thank you, Werner. Appreciate the question. So for both of you, you know, some patients these days are being offered the new cellular therapy CAR T. Do these new therapies pose any dangers to the kidney?
I mean, I don't think so per se. Now, if the CAR T cell were to go after a target that's expressed on kidney cells, that would be a different story. I would say the most common, in my book, the most common problem with CAR T cells is the cytokine release syndrome, loss in blood pressure, and then acute kidney injury, for example. Things of that nature, I would say I would be more worried about. And so, yeah, I don't know of any specific other particular issue there. Dr. Abrams, maybe you could.
Yeah. So in the kidney cancer patient population, I haven't personally had any patients who receive CAR T cell therapy, but I have seen many patients for other indications receiving CAR T cell therapy, and there are quite a few studies. Acute injury of the kidney is pretty common, and it's like Dr. Hammer said, it's related to that inflammatory release you get with the CAR T. The good thing is that happens in the hospital. So the numbers are watched very closely, treated appropriately, inpatient consults as needed. And the outcomes for those patients are usually very good. Most of them recover kidney function fully. So, you know, I don't think I think it's probably a good option for patient. If that was an option for kidney cancer, that would be a good option from the nephrology perspective. Of course, there are rare case reports of problems, but the majority of patients do very well from a nephrology perspective with CAR T cell.
It should certainly not discourage a patient who's considering CAR T cell therapy for kidney cancer to do so. So let's put it this way. There could be some really nice opportunities, and just because you have one kidney, for example, that should not be a consideration not to think about those opportunities that may present yourself.
Okay. And on those occasions that a patient does need to move on to dialysis, is it possible to continue treatment while they're on dialysis?
Yeah, so fortunately, I've not caused too much dialysis. So to be very clear, I feel guilty about many things, but I can count on, you know, maybe like actually one patient probably, and that was immunotherapy related. But it's really rare. I mean, I cause so much more trouble with other things. I would say it's really more like, you know, I would say dialysis as the endpoint, so to say. If there's dialysis, or sometimes, as Dr. Abramson mentioned, you know, kidney cancer arises on chronically injured kidney tissue. Let's say the cystic kidney disease that he mentioned, for example, or even chronic use of NSAIDs, high blood pressure, diabetes. So it's not uncommon. In fact, kidney patients on dialysis are at increased risk for kidney cancer, especially if the kidneys remain, the chronically injured tissue remain, they're going to be at increased risk. So it's not uncommon to actually have a scenario where you have a patient on dialysis with metastatic kidney cancer. The good news here is it does not restrict me in the drugs that I want to deploy. The good news here is that the pills, the VEGF inhibitors, they're virtually all of them are eliminated primarily through the liver. There might be some metabolites, some of them with the kidney, but the vast majority goes through the liver, meaning that pathway of elimination is not an issue in comparison to some other drugs that may be primarily eliminated through the kidney. That would be a different story. So the pills are not an issue. You can give it even somebody who doesn't have kidney function. Immunotherapy are antibodies, so they're not going to get clear through the kidney either. And so that's also not in the way. So I would say the two main drugs of therapy for kidney cancer right now, classes of drug, they're not a contraindication in patients who are on dialysis.
Great. Well, from the great state of Texas, one of your neighbors, we have Evelyn coming up to ask a question. So,
hi, Evelyn.
See, Evelyn.
Hi, it's good to see all of you again. So I have a kind of a two-part question. What's the impact of adrenal insufficiency on the kidneys? And does taking a too low dose of hydrocortisone due to non-functioning adrenal glands have any adverse effect?
On the kidney function, again, I can give you my spiel, and Dr. Abramson can. So, I mean, personally, I don't see a real connection there per se. I think, you know, the adrenal gland is an endocrine organ, just sits close to the kidney. But in my book, they're two separate organs. And as long as you have adequate supplementation, your blood pressure should be fine, perfusion should be fine, etc. Now, if you don't take enough, because you're either stubborn or forgot your medication or whatever happens, you may actually be in a situation where the blood pressure may be soft, you may have less perfusion, you may even get an adrenal crisis if you forget your medication and go on vacation. So those could be scenarios that I would think about, really more like a perfusion blood pressure issue. But Dr. Abramson, help me out there. You're my lifeline.
Yeah, so thank you, Evelyn, for the question. That's very interesting. Adrenal insufficiency itself, adrenal insufficiency is relatively common in kidney cancer patients, whether it's due to removal of the adrenal glands from surgery or from immunotherapy causing some suppression of a hormone release from the brain. So we do see patients with adrenal insufficiency, not often. If it's primarily due to the removal of the adrenal gland, it's not usually does not usually impact the kidney per se. If you're not on appropriate medications to treat it, then yes, you can develop some electrolyte abnormalities like high potassium, at high acid level in the blood, which can also be medically managed, but the ultimate treatment is supplementation of the hormones that you're missing. If the adrenal insufficiency is related to the immunotherapy, that can also coincide with kidney problems, but the treatment is the same. The way you treat the adrenal insufficiency is the same way you treat the kidney injury, usually with steroids.
Great, Evelyn, thank you very much. Appreciate the question. We're getting a lot of questions around nutrition, and questions around salt intakes, sugar, any advice, etc. And I know there's a lot of information out there. We also have some at our website. Any general comments to start? I'll let Dr. Hammer start, and then Dr. Abramson, you can be the lifeline again.
Yeah. So my cop out is that I always say, stay, keep a healthy balance of the various things. So I'm not I don't know. There's, it's difficult to say that diet would control, for example, kidney cancer. I think having a healthy, balanced diet in general term, in my book, is just the best way to be, right? Some patients, obviously, they want to be active, they want to be in control, they want to do certain things. They may get a lot of well-meaning advice from family, friends, online literature, whatever. But I would say maintain a healthy weight, regular exercise. If you just eat brisket, that's not healthy for you. If you just live off refined sugar, that's not healthy of you. But if you have enough vegetables and other things, the occasional pecan pie on Thanksgiving, I wouldn't say no to that. And so I would, I think that's how I see it. I think, to be honest with you, quite frankly, from my perspective, my biggest concern if patients lose too much weight by adding a diet on top of the toxicity, for example, that I give with the VEGF TKIs, right? So they're notorious for metallic taste, mouth sensitivity. Your favorite food is not your favorite food anymore. You think your wife or your other partner or yourself, you cannot cook anymore. It's hard to maintain a healthy weight on these pills. And so I'm to be honest with you, I'm more nervous about patient losing weight than anything. So I discourage typically any extreme changes in diet, but that's all my knowledge, so to say, and I will give it over to Dr. Abramson and see what he says from his nephrologist perspective.
I 100% agree with Dr. Hammers. My major concern in seeing cancer patients in my clinic is weight loss. So There needs to be enough caloric intake to ensure that there's not weight loss. Probably weight gain is needed in many cases. I think that, in very strict diet recommendations are usually not necessary until the kidney function is very low, like usually less than 30%. For example, potassium restriction or phosphorus restriction, I'm just using these words, but you might have heard of them. Those restrictions are only required if you have a very high level of either of them. So that would require kind of a multidisciplinary approach with a nutritionist. If you don't have problems with your potassium or your phosphorus, you can just like Dr. Harmer said, eat a well-balanced diet. If you want to be as super healthy, there's some literature to suggest switching some of your animal-based protein to plant-based protein may be helpful, especially if you have advanced kidney disease with a kidney function less than 30, or you have protein leakage in the urine. It may be helpful. It's not entirely proven, but it's certainly not harmful.
How about as far as we just have a couple minutes here and a lot of questions around either water intake, fluid intake. There's also a question around alcohol intake, and also we'll just throw in there a question about contrast when you're getting scans. Any of those, I'll give you a.
Yeah, so first of all,
whoa.
So first of all, the fluid intake, please, Dr. Everson, tell me, because my patient asks me all the time how much fluid they should drink. So why don't you give us the nephrologist, the hardcore nephrologist perspective on the recommended amount of fluid? I think that's a really good one.
So fluid intake in general, overhydration can be a problem. So drinking more than you need. How do you know how much you need? Usually it's by your sense of how thirsty you are. If you feel thirsty, you probably should drink, with some exceptions. Aiming for a certain amount of fluids every day, like 2, 3, 4, 5 liters, is not helpful, and in some ways it's harmful because it can cause overhydration and electrolyte problems. So follow your sense of thirst. Drink more when you're active. Drink less when you're sedentary. If you eat a lot that day, you probably will need to drink a lot more. If you eat less that day, then you drink less. Sometimes your creatinine may look lower if you drink a lot of water, but your other electrolytes may become diluted as well, and it's not actually an improvement in kidney function.
Can you give us a number, like ounces? I know there will be some patients who are like, I don't know what you just said. Give us some numbers. Like what is the one for the sedentary person, and what's the one for the more athletic guy?
I think that if someone is just eating a normal diet but is sedentary, probably like 1 or 1.5 liters is probably enough. 2 liters is more than enough. If you're very active, up to 3 liters probably.
And the liter is a quart, right? Is that right? A liter is a quart, roughly?
Yeah. So, things like Gatorade or those things are basically water. So if you're, it's not the wrong thing to drink Gatorade or something like that, but that's essentially mainly just water and sugar.
Good. Well, I think we're coming to the end here, and we could probably keep asking some more questions. We're gonna.
One more thing.
Okay, good. Overtime.
The contrast. That's one of the most frequently asked questions. Is the contrast, doctor? I have just one kidney. Tell me about the contrast I can have. When do you need to be careful with CAT scan contrast? And what about the MRI contrast?
Yeah, so there's been a movement in the nephrology world to almost ignore problems related to contrast from scans. Iodine contrast from a CAT scan, which is usually iodine contrast, it really hasn't been shown as an independent risk factor for kidney injury. Those are the days you may actually want to increase your fluid intake, because you want to expel the contrast, because you don't want it sitting around in your system. So the more fluid you drink actually on the day of contrast, they may actually be helpful. If you have very low kidney function, definitely talk with your nephrologist and oncologist to see if a little bit of IV fluids before, or sometimes maybe stopping some of your medications before that may just reduce your risk of having a kidney injury. But there's really no cutoff anymore for getting contrast with a CAT scan. The same goes for MRI, actually. MRI uses a different type of contrast. It's called gadolinium, and that's actually not toxic to the kidney. In somebody with stable kidney function, doesn't matter really what the function is. The new guidelines don't recommend anything. You're allowed to have that gadolinium contrast from the MRI. everything is everything is more nuanced the more you look into it. If there's any concerns, the radiology won't do anything if they have concerns, so they'll reach out to your providers as well if needed.
For sure, and they're not nearly there where you guys are already. They're much more conservative when it comes to contrast the radiologists. Many of them.
Very true. Very true. Yeah, they have some centers still have arbitrary cutoffs for both CAT scan and MRI.
Arbitrary. Totally arbitrary.
But can be overridden if needed.
Very good.
Man, I feel like I'm putting a bucket of water on a great fire that we could sit around and listen to all night and watch. Anyway, thank you so much. Thank you to our audience out there for spending the hour with us. It went by really fast. Especially want to say thank you to Dr. Abramson and Dr. Hammers. Thank you so much. We're getting a lot of chat noise saying how much fun and interesting this has been. Really appreciate your time tonight. And thank you to our sponsors, BMS again, ASI, Exelixis, Genentech, and Merck. We really appreciate your support. We couldn't do it without you. And if you'd like to rewatch this town hall or share it with your family and friends, it'll be available on our YouTube channel by the end of the week. Once the video is uploaded, you'll receive an email from KidneyCAN with the video link and some other resources that were shared tonight. Our 2024 Town Hall series will kick off in February. We usually do it in January, looking back, looking forward, but next year, ASCO GU's at the end of January. So our first Town Hall will be in February when we're doing a looking back and looking forward Town Hall on what's going on in research. So if you have some more time tonight, join us at the social hour. You should have gotten the link. It's in the chat. We'd like to say hello to those friends out there. So again, thank you very much for joining us tonight. Dr. Hammers, Dr. Abramson, really appreciate it. Thank you.
Thank you,
My
Brian.
pleasure.